our audience in our Hancock County were the primary care clinicians in the area, because we wanted them to become more open to the option of perhaps prescribing some Suboxone or MAT services to their patients. And so when we went around and met with the different groups of primary care clinicians, we started out just outlining what we all know, and that our mission is to save lives when possible, to cure sometimes, to relieve often, but always to comfort. And if we could have the next slide. Leading factors contributing to death, we know these. 17% of deaths, tobacco has contributed significantly to them, alcohol another 10%. The opioid crisis is now doing 4%, which is more than the old car crash, which is now just 3.5%. And so we sort of like to remind all our clinicians that to fulfill our mission, we should at least be treating addiction and wearing our seatbelts. So next page. Pain is a gateway to addiction, and since most patients believe that pain means their disease is getting worse or death is getting closer, pain always requires some level of adaptation, and substances often help the patients feel like they're adapting to the physical and emotional pains. Let's look at the next slide, and you'll see most clinicians in primary care know that a lot of their sort of presenting problems are pain, and an honest faculty in Boston said that 30 to 50% of the patients with chronic pain develop addiction problems. And then, being even more honest, they said that increases to 90% if the patients have at least 2 of these risk factors. So again, I would ask the primary care clinicians to think about all the patients that come into their primary care centers who have had a history of child abuse, have problematic or prolonged recovery from any previous illness or surgery, that have current job dissatisfaction, that have a sort of quick to anger and anger proneness sort of disposition. And then if they have any other substance use disorder or major psychiatric disorder, you're really talking about a group of people who will have a 90% chance of becoming addicted to a substance if they use it. Next slide, please. So we'd like to ask all the primary care clinicians, how many of your patients come to you with problems of pain? And it's a majority for most. Next slide, please. Now, the first thing that a primary care clinician will say is that they're already overwhelmed. Why in the world would they need or want to think about taking on another group of patients? So we found in our work here in Hancock County, we needed to be honest and upfront by offering them a memorandum of agreement. In other words, what do we expect of the primary care clinicians, and how much can they count on the Hub Treatment Center clinicians? So let's look at the next page. We said this in a document that we had the primary care clinicians sign, that their responsibilities were first to identify which of their patients might want the medication-assisted treatment, and then complete a physical exam and help certify that they're able to participate in the Hub Treatment Center. We'd like them to continue taking care of their patients' physical health problems while they're being stabilized in the Hub Center. Next slide. Then when the patient has been stabilized in the Hub Center, we hope they would be open to us calling and saying, would you be willing to see them once a month to continue their stable MAT treatments? And then, very important to the primary care clinicians, if the patient they accept back relapses, begins missing appointments, or starts having unacceptable urine tests, then they need to know that we promise to take them back into the Hub Treatment Center to be further stabilized. Next slide, you'll see what the responsibilities are for the hub clinicians. We would be taking in the patient, doing the substance use evaluation, trying to help them actively engage in the group therapies, keep pushing them back to have their general health problems attended to, because so many times when they're in the throes of the opioid use, that becomes their only part of healthcare that they're willing to reach out and take. So then when they've been stable in the hub for 3 to 6 months, we will call the primary care physician and ask if they're willing to provide the monthly supervision. Next slide. If they are willing to assume it, then we will facilitate the transfer of the patient and make sure the patient has enough of the MAT medication to carry them to the next appointment. And then again, we promise if they request that we will readmit the patient to the hub center. So let me have the next slide and just pause a minute and ask if anybody has any questions at this point. If not, let me share with you 2 of these guidelines that we came up with in our group of interested stakeholders in the whole problem of the opioid abuse. And as you see, these were approved back in 2015. We've had them available. The 2 we're going to look at today are tobacco or nicotine and opioid, just to show you how we treat them in such similar manners that most primary care clinicians, when viewing it from this perspective, can say, well, yeah, I think I can do this. It's not really that different in the steps that I take from treating nicotine dependence, which is something I do every day of my practice. So let's see the next slide. So with nicotine dependence, which of course is repeated use despite the harm that we know comes from nicotine, there is screening available. You want to find out exactly what they're using, how they're using it. Then the second thing, there are some overdose of nicotine problems that do come up. And of course, how we treat that is we decrease the nicotine. And in severe overdose cases, sometimes we have to bring them into the emergency room and sort of support them until the nicotine diminishes to a point where they're no longer overexcited in their central nervous system. Next slide, please. Then we can sometimes detoxify using decreasing doses of nicotine, and we do that with all kinds of nicotine products, which I'll show in a later slide. Then the treatment options, you see a list here of all the community resources. There are many more than this, and in the Appendix E of the Healthy Acadia sort of attachments that have all our protocols on them, you have a longer list even than that. Next slide, please. Then medication-assisted treatment for nicotine dependence. A lot of people don't think of the patches and the gum and the lozenges, the inhalers, the nasal sprays as medication-assisted treatment, but they really are. And so, of course, the Wellbutrin or Zyban and the Chantix are also medication-assisted treatments for this very common and, unfortunately, contributory illness that can cause death in our culture. Then lastly, we don't want to forget about the psychosocial treatments, because some people, despite their best efforts, can't seem to get away from the nicotine, and they can have talking therapies in their primary care health centers if those services are available, and if not, then referral to some specialty behavioral health providers are available as well. So now let's go to the next slide and see if we can just how similar treating opioid dependence really is. So at this point, I hope the primary care clinicians are seeing that, yes, once again, I do assessment, and you even have a help with the assessment, because now you can get the prescription monitoring program report before you see the patient. You can go over it with the patient and let them see the number of opioid scripts that they have been having dispensed to them over the years. You have the screening, brief intervention, referral for treatment. You want to again know how much, how they use it. You want to see how motivated they are for treatment. And then again, the second thing we look at is overdose prevention, reversal options. Last few years, we've had Narcan become much more available to the community, and hopefully this is now available whenever it is needed, and hopefully will help to reduce the total number of overdose deaths. Next slide, please. Then detoxification, if someone is wanting to take themselves off of their opiates, wants to sort of do it with your help as a primary care physician and doesn't want to use one of the methadone or buprenorphine options, then clonidine can often help for body aches, Phenergan can help for nausea, newer agents are also available, Bentyl, Vistaril for diarrhea, Imodium, and then some medications available for sleep problems as well. Let's look at the next slide. Treatment options, again, they're available. You know them, and many of the same ones that you use for alcohol and for and can use for nicotine as well. And there's more options listed in the appendix of the Healthy Acadia resource guide. Next slide. Then the comfort medications to support abstinence. Now, it's important that this is not a substitution for real, what we call medical assisted treatment with opioids, but you see many of the medicines we listed before. The clonidine for musculoskeletal system, Phenergan, Doxepin, Neurontin for neuropathic pains, Bentyl for abdominal cramping, and Vistaril for anxiety. Next slide. Now, the 4 FDA-approved agents at this point for medication-assisted treatment are methadone, which is a full agonist. It's just as potent a opioid as anything that is ordered by a physician to help reduce pain. Buprenorphine is a partial agonist, and there are some advantages to that, and it's why it can help a patient kind of take away the worry about withdrawal symptoms, but doesn't give them the full effect or nod of the opioid patient. We mentioned here that, and I put in later, that now there's an implant. You know that we have the pills and the little film that you can put under your tongue. They also have one now that sticks to the side of your cheek, and there are some monthly injections that are also available to this. By and large, most of our patients, and for the affordability factor, it is the Suboxone film that is most often used. More and more data is showing us that there's really not a need with most pregnancies to switch over to Subutex, and so more and more what we see is that Suboxone is the agent that will be used in the primary care setting to help these patients. Now, Trexone is the 3rd approved agent, and this is for the person who wants to stop using opioids altogether. It is an antagonist agent and can be very helpful. You've heard it also talked about as Vivitrol, which is given once a month, but for the expense, I think would be a much more useful agent. And then there's naloxone, which is Narcan, that reversal agent in case the patient relapses and can help save their life. It comes both in a nasal spray and an intramuscular injectable. Then if, again, these MAT agents are, I would say, almost never completely effective without some psychosocial treatment. That can be one of the 12-step programs. It can be talking therapies in the primary care health center. It can be with any number of experienced therapists in the community, and it can also be in specialty behavioral health centers as well. And then I think the last slide just shows you the Healthy Acadia homepage, and the fact that all of this in greater detail and the forms and protocols are available through this website.